All right. Welcome, everybody. We're going to give a couple of seconds for everybody to join the webinar. Thank you so much for joining us today. Give you all just a second here. Thrilled to have everybody joining us today on the rarest of days, February 29th, Rare Disease Day. We're really thrilled to have you join us to talk about living with HoFH in 2024. So I'm going to start off here just in a second with an introduction and a little bit of some housekeeping items, and then we're going to get to our main event with our speaker, Dr. Goldberg. So again, welcome everybody and thanks for joining. My name is Allison Jamison, and I am a board member at the Family Heart Foundation, and I am a patient ambassador, and I'm also an individual who lives with homozygous familial hypercholesterolemia. So obviously this is a topic that is very near and dear to me. By way of introduction, so how I sort of ended up at Family Heart and why I'm here with you tonight. I think for a lot of us who've been impacted by homozygous FH, we have some similarities and some differences in our stories, and sometimes the path to diagnosis can be circuitous. For myself, I knew early on that I had FH. I had xanthomas present at age 3. At age 5, my total cholesterol was checked, and it was somewhere near 900. So my family knew there was something going on, diagnosed with aortic stenosis at 13. But it wasn't until after I had 2 bypasses, 2 valve replacements, and a heart attack that I was finally diagnosed with homozygous FH at age 35. So that's why I am so passionate about continuing to raise awareness for this condition and to talk about it. And I'm just honored to have found the community at Family Heart that supports me and others like me. And again, we're thrilled to have you here tonight. So we'll go ahead and advance to the next slide. We'll get started. And we'll start with just a couple of disclaimers here. Of course, this webinar is for information only and is not intended to be medical advice. If you have questions about treatment for yourself or your family, please check with your doctor and your healthcare team. I also want to share with you how you can interact with us tonight, and we hope that you will. You've got 2 buttons here on your webinar would allow you to interact. There's a chat function and the Q&A. We would love to hear from you in the chat. You can click on that and please click everyone and then give us a shout out. Let us know your name if you're comfortable sharing, where you're from, why you're here tonight. Are you someone living with HoFH? Are you someone who cares for individuals with HoFH? We would love for you to share a little bit about yourselves and let everybody here know that you're here with us. So please use that chat function. We would love to see you there. The other opportunity we have is in the Q&A box. So the Q&A will be there throughout the webinar. We have a period of time designated for question and answer, but you're welcome to put questions in that box as we go throughout tonight's presentation. And then we'll ask your questions live with Dr. Goldberg, or we'll answer them in the chat. We can do that as well. Feel free to put them there, but as I said, we'll answer all of those at the end. All right, and on the next slide, we'd just like to thank, there are a lot of people that help us put on programming like this. We'd like to thank the Regeneron as a sponsor of our HoFH Community Activation Program. So thank you for that. All right, and now we're getting ready to get to the main event tonight of living with homozygous FH in 2024. I would like to give a brief introduction of Dr. Goldberg, and then I'll let her take the presentation. And keep in mind, this is just a brief introduction of her many qualifications. Dr. Goldberg is an endocrinologist and lipid specialist. She received her undergraduate degree from Radcliffe College, Harvard University in Boston, and her medical degree from the University of Maryland. She completed internal medicine residency at Michael Reese Hospital in Chicago and fellowship training in endocrinology at Washington University School of Medicine in St. Louis. She then joined the faculty of Washington University School of Medicine, where she is a professor of medicine. Her research and clinical interests include dietary modifications and drug therapies for hyperlipidemia and the treatment of familial hypercholesterolemia. And she's conducted numerous clinical trials of lipid-modifying drugs and cardiovascular outcomes. She's a fellow of the American College of Physicians, the American Heart Association, and a master of the National Lipid Association. She's the past president of the National Lipid Association and the immediate past president of the foundation of the National Lipid Association. She chaired the National Lipid Association expert panel on familial hypercholesterolemia, and she's currently the chief science officer of the National Lipid Association. So Dr. Goldberg, thank you so much for joining us here tonight. I will turn it over to your very capable hands.
Thank you so much, Allison. I'm really pleased to have been asked to talk about homozygous familial hypercholesterolemia. It's been a passion of mine for something around 40 years. Next slide, please. So the agenda for this talk is to answer several questions. What is homozygous FH and how is it inherited? Why is homozygous FH or HoFH diagnosis often missed and treatment delayed? What needs to be done when HoFH is diagnosed? What's the treatment for HoFH? And where can families get help? Next slide. So what is homozygous FH and how is it inherited? Next slide. So think about it as HO, homozygous, 2 inherited genomic markers, plus F for family history of early cardiovascular events, plus H for high LDL cholesterol, LDL levels starting at about 400 and going up from there, equals HoFH, or homozygous familial hypercholesterolemia. Next slide. Next slide, please. There are 2 forms of familial hypercholesterolemia, which will be shown in the next couple slides. And that would be heterozygous familial hypercholesterolemia, or HeFH, and homozygous familial hypercholesterolemia. So here we are. So heterozygous FH is 1 gene variant or mutation that causes high cholesterol, and this is in families. Homozygous FH is 2 FH variants or mutations, and this is the most serious and rare form of FH, causing very high cholesterol. Next slide, please. So HeFH is relatively common, about 1 in 250 people. It's 1 gene. The typical levels start at about 190 milligrams per deciliter for the LDL, although sometimes it's lower, and a cutoff of about 160 milligrams per deciliter for children. The onset untreated of heart disease in heterozygous FH is about 30 to 60 years. Most respond to drug therapy, usually needs combination drug therapies, and is common. Homozygous FH is rare. 2 genes are involved, either the same or different genes. Typically, the levels are in the range of 400 and above. And you can see in untreated disease, CHD onset in childhood. It may not respond as well to the usual therapies, but many respond to new medications and other things. And it is rare, about 1 in 300,000 people. Next slide. So just to emphasize, we're talking about very high LDL cholesterol levels. 400 is about 4 times what LDL should really be. Next slide. So FH is inherited. So in the heterozygous pedigree, you see that the gene can be passed down from a parent to a child, to that person's child, to that person's child, and it is not related to sex or gender. It can go from a mother to a son, from her son to his son, or to his daughter, or to their granddaughter. The homozygous pedigree, if both parents have FH, each child has a 1 in 2 chance of having heterozygous FH, so having 1 gene, and a 1 in 4 chance of having homozygous FH, that is 2 genes. And each child actually has a 1 in 4 chance of being normal. Next slide. So the physical findings in a homozygous FH are not always present, and they're often misunderstood and thought to be something else. And on this slide, you can see various types of xanthomas and other things. So in the group of 6, you can see these skin conditions, which are kind of raised, yellowish, whitish things on the skin, sometimes in the crook of the elbow, sometimes on the hands, the feet. Sometimes they're big, they're very big. Sometimes they're not as big. The classic finding are Achilles tendon xanthomas. So in the Achilles tendon, you can see thickening of the tendon. Sometimes it causes a tendonitis in people. Xanthelasma are the little patches at the inner sides of the upper and lower lids. They're kind of yellowish to whitish. They can be seen in other cases that are not homozygous FH. And corneal arcus is a ring around the edge of the iris, sometimes very, very easy to see. It can be seen in older people, but when you see a big ring like this all the way around in a person under the age of 40, that is often familial hypercholesterolemia. Next slide. So this is actually a very lovely family with a very lovely child, and her mother, Jessica, was noticing these bumps on Reese's knees. And so she went for a long time thinking she had a healthy child, and it took a long time for these bumps to be diagnosed. Her pediatrician said that he had had children in his practice with high cholesterol, but had never been that high. Next slide. So what about genetic testing? This is kind of, one of the best ways to make a diagnosis, but you don't need the genetic testing per se. It should be offered to individuals with suspected homozygous FH and family members, and it can help. If the test confirms HoFH, it can help to qualify for the medications approved for HoFH. However, you can be diagnosed with HoFH without having this confirmed by genetic testing, and people with this diagnosis should still get medications approved for HoFH. Next slide, please. So the problem with very high LDL is that it accumulates in the arteries and causes blockages, atherosclerosis, and these build up over time, and the higher the LDL, typically the faster the blockages build up and can lead to heart attacks, can lead to blockages leading to strokes, can lead to blockages to the big arteries in the legs, and can also, with homozygous FH, you can see aortic valve stenosis, where the main valve leading into the aorta from the left side of the heart gets really squeezed down and very, very hard and doesn't let the blood flow through, and is a significant condition. Next slide. Untreated FH leads to high LDL levels and the exposures from birth. And so if you look at where it says cumulative LDL cholesterol, I mean, basically it's like tobacco, and the more you smoke and the longer you smoke, the more damage you see. LDL is toxic to the arteries, and so starting from birth, the higher it is, the more effect you get. So for the blue line that says homozygous FH, the threshold for average time when people develop heart problems is 12 and a half. It's somewhat delayed in female sex, and things like smoking, high blood pressure, the very high levels, and other things can make it earlier. The heterozygous form average for men would be about 35 untreated to have an event. It's about 10 years later in women, but other things, again, if you add other risk factors like smoking, hypertension, diabetes, etc., it can cause an effect. The bottom line represents no FH, and that an average age of having a heart attack or some blockage would be about 55. Next slide. However, this is untreated, but we can do something about FH. We can treat it, and it makes a difference. Next slide. So what about finding HoFH, and why is it missed? Why is it treatment delayed? Next slide. So the diagnosis is missed and delayed, and the Family Heart Foundation research suggests a number of reasons. First of all, there have been conflicting recommendations about screening from the American Academy of Physicians and NHLBI versus other groups. And even with recommendations, there's a lack of screening. And even if screening takes place, many clinicians fail to connect the dots. Clinicians think that HoFH is so rare that they will never see it. And when they do, there's a failure to recognize it. Also, many clinicians think all children with HoFH will have physical findings, and they won't necessarily. And they often don't take the kind of family history that is needed. So just a parental history may not tell you anything. For a young child, you may have to go to grandparents and great-grandparent history to figure out what's going on. Next slide. So universal pediatric screening is the best way to diagnose HoFH, but it as often as it should. The recommendations have been out since 2011 that all children between the ages of 9 to 11, and then again at 17 to 21, get screened. This is from the American Academy of Pediatrics and from the National Heart, Lung, and Blood Institute of the National Institutes of Health. In fact, children with a family member with FH or a family history of heart disease should be screened by age 2. And the main rationale for screening is to identify children with FH. Next slide. So, and then really the universal lipid screening of all children is really critical to make sure that we get timely diagnosis and we treat all patients with HoFH. Such screening also can allow the diagnosis of parents who have undiagnosed heterozygous FH. Two parents may not know they have high cholesterol until they have a child that has HoFH. Patients with HoFH need urgent treatment, multiple lipid-lowering agents to the LDL levels that are at goal. And the diagnosis will allow access to the newer therapies that are specific for HoFH and where you don't need all of the LDL receptor function that is required. They can bypass, the new treatments can bypass the things that other drugs work on. Also, increased awareness of FH, both kinds, HeFH and HoFH, is critical, and it will allow diagnosis and timely referral to specialty clinics. Next slide. So what needs to be done when you do make the diagnosis? Next slide. So first of all, you need to look at the whole person and check for other risk factors and work on them. Smoking is a huge problem. Smoking just makes everything worse. Tobacco use. So any tobacco use should be stopped. And, you know, when the younger that you get the person, the more you can sort of make them know that really using tobacco is a really bad idea. And you want to treat blood pressure if it's high, treat blood sugar, etc. Then the other thing that needs to be done right away is referral to a cardiologist, either a pediatric cardiologist or adult cardiologist, depending on the age. You want to look at the heart valve. So the special heart ultrasound called an echocardiogram can look at the aortic valve. And then you want to evaluate the heart arteries to see if there are blockages. And the coronary artery test that is the standard of care now is called a CT angiogram. And then you want to look at other arteries sometimes, the carotid arteries, and then the arteries to the legs. Next slide. Then you want to look at other family members. So the person, the little dot in the center here is the person with HoFH, and the first circle are their first-degree relatives, so parents and siblings. The next circle would be cousins, aunts, uncles. So you want to test the first-degree relatives and then all of those people. And so this is a spreading circle where you test people who are related to people with FH. Next slide. Then treatment. Treatment is started as soon as the diagnosis is made. There's no delay. You just start right away. Next slide. So what is the treatment for HoFH? And I'm going to talk about some of the medications, although not all of them in detail. Next slide. So what do we want to achieve with treatment? First of all, HoFH has to be treated aggressively as soon as we diagnose this, and it doesn't matter what the age of the person is. Everybody is at high risk. And in fact, what we do a lot of times in the lipid field is we evaluate people's risk to decide what to do with them. And this is not done in HoFH. Everybody's high risk. You just don't even use a calculation. The goals of treatment in primary prevention, that is people who've never had a heart attack or any known blockages, is an LDL below 100. For secondary prevention, people who've already had a known blockage somewhere, LDL is less than 70. Pediatric goal is at least less than 130. We'd like to get it as low as we can. The idea is that if we get the LDL cholesterol down, this reduces the risk of heart attacks, bypass surgery, stents in the arteries, stroke, peripheral artery disease, early death. And we usually need combination therapy for HoFH. There are a bunch of treatment options: statins, ezetimibe, PCSK9 inhibitors, bempedoic acid, bile acid sequestrants, apheresis, and then for homozygous FH only, lomidopide and evinacumab. Most insurance plans cover combination therapy when the LDL is above treatment goal, but it often requires a prior authorization, a ton of paperwork, sometimes multiple appeals necessary to get approval. Next slide. So we've come a long way. I started doing lipids in 1983. And we had bile acid sequestrants that had been around since 1973. We had a couple other things like niacin. September 1st, 1987, the first statin, lovastatin, came on the market and could be prescribed. It's made a huge difference. Lipoprotein apheresis became available in the US in 97. Ezetimibe became available in 2002. Lomidopide in 2012. Evolocumab and alirocumab in 2015. Bempedoic acid in 2020. Evinacumab in 2021. And inclisiran at the end of 21. Next slide. So we start the standard treatments immediately. Everybody gets started. High dose statin. Statins decrease, these are HMG-CoA reductase inhibitors. They decrease cholesterol made in the liver. This works to increase LDL cholesterol removal. It upregulates, that is, it makes the LDL receptors, those molecules on the surface of a cell that take up LDL, it makes them work better. It's 1 pill a day, and in spite of everything that you've read and seen on the internet, it is safe and well tolerated by most people. Probably 90% of people could take a statin. Ezetimibe reduces cholesterol coming from the intestine, and it increases LDL cholesterol removal also by making the LDL receptors work harder. It's also 1 pill a day, and it's very safe and well tolerated. Next slide. So the newer treatments, the 2015 treatments, alirocumab and evolocumab, attach to a liver protein called PCSK9. PCSK9 affects how well the LDL receptors work. So when you block this protein, you increase LDL cholesterol removal. And these are done by injections at home every 2 weeks or once a month. Next slide. So the specific treatments for homozygous FH are lomidopide and evinacumab. Lomidopide helps block the liver, keeps the liver from making particles that turn into LDL. It's 1 or 2 pills a day, depending on the dose. It is approved for adults with HoFH, but there's some new data that show it works in children and adolescents. It requires following a pretty low-fat diet, taking vitamins, and monitoring liver tests, since it can cause fat to build up in the liver. Evinacumab increases clearance of LDL. It's an intravenous infusion once a month, and sometimes it can be arranged to be done at home. It's only approved for homozygous FH, and it's approved in adults and children starting at age 5. Next slide. So lomidopide works in children with HoFH. It's not approved in the US yet. It's been studied in children 5 to 10 and 11 to 17. And you can see the numbers are not big because because this is a rare disease, and typically about a 50% reduction in LDL. Next slide. So I'm going to show you kind of the effects you can expect of various medications in heterozygous FH. These may give you nowhere near the same drops in homozygous FH. It really depends on the situation. And these tend to be all additive. So diet, 10 to 15%. Statins 35 to 55%, ezetimibe at an additional 18 to 25%, a bile acid sequestrant called colesevelam 18 to 25%, the 3 PCSK9 inhibitors, rapatha, and the newer one, inclisiran or Leqvio, anywhere from 40 to 65%. Bempedoic acid and its combo with ezetimibe can do anywhere from 17 to 38%. Next slide. And then there's apheresis. So apheresis, as I said, we've had for over 20 years. It's done once every 2 weeks or once a week in heterozygous and in homozygous FH. It's done in specialized centers with specialized machines. You can see the machine. You hook up things. It takes about 3 hours. There are about 40 centers. It usually takes either 2 intravenous lines or another form of access. Next slide shows an adult and a young child getting apheresis, and most of these are done through what is called an AV fistula, which is the way you actually do dialysis. Next slide. So here's what we can expect from apheresis. Now, right after the apheresis session, you get a really, really huge drop in LDL, but since it's produced all the time in the body and not cleared very well, it goes up again. And so you end up with about a 22 to 48% time averaged drop. The lomidopide, about 40 to 50%, and the evinacumab, on average, about 49% drop in people with HoFH. Next slide. So the problem is that HoFH is diagnosed too late in a lot of people, and people with lower LDL levels on multiple medications do better than those on fewer medications. So we want to start early to move the curve. And as you can see from this diagram, it shows event-free survival. So the number of people not having something happen. And the bottom line are the people with the highest LDL. The top line are the people with the lowest LDL. And you can see that as you move from that low line to the top line, the events occur later in life and there are fewer of them. So greater use of multiple medications is associated with lower LDL levels and better outcomes. Next slide. The other thing that has really been helpful are clinical trials. I do clinical trials. That's one of the things I do. And getting people into clinical trials can be a real benefit for them and for society. So many patients may benefit by participating in a trial. And when patients with HoFH join trials, it can help move new treatments toward approval by the Food and Drug Administration. So if you want to find a trial, you can go to the website, the NIH website, clinicaltrials.gov, and do a search. You can also search for clinical trial resources in the Family Heart Foundation website. Next slide. So where can patients and families get help? Next slide. So there are resources in the Family Heart Foundation, and next slide shows you a couple of the things that you can download. You can download forms that tell you all about HoFH, and also about all the different types of medications and other things that will help, and what to expect. There's a lot of information on the familyheart.org website about FH, about HoFH, and about HoFH. Next slide. So to summarize, very high LDL cholesterol is a known risk factor for cardiovascular disease, but often goes untreated or undertreated, even at the highest levels. HoFH diagnosis is often missed. When it's made, it's often delayed. The clinical diagnosis can be made based on an LDL cholesterol over 400 and a family history. And cholesterol screening in adults and children is the key to finding people with FH and HoFH. So when you find somebody with, or you have been found to have an LDL cholesterol over 400, people need to be treated urgently. They've got to get on the treatments that we have available today so we can get the LDL down to better levels. Next slide. The key takeaways are that early aggressive LDL cholesterol lowering with combinations is necessary in homozygous FH. And if the LDL cholesterol is over 400, you want to see if it is HoFH. And you can find a specialist and connect with the Family Heart Foundation at the number shown here. And there's a whole listing of specialists on the website as well. Next slide. So I want to thank you for having me, and we'll be happy to take questions.
All right, thank you so much, Dr. Goldberg. I've got a list of questions here, and I think the first one that came up kind of encompasses a number of questions. So this may have a couple of levels to it, but the question is, sometimes what medications work might depend on the genetic variation that somebody has. So if someone has 2 null receptors and doesn't respond to statins, do you still start treatment with statins? So I guess sort of inherent in that question is different kinds of mutations, and also is there a standard progression of treatment?
So actually, it is worth starting everybody on the statins because high-dose statins decrease cholesterol production in cells and can often give some benefit even when people have no LDL receptor function. And in fact, there's some interesting data out of the Netherlands on this, where there are people who are null, that is, they have no LDL receptors, and some of them respond actually fairly substantially to statins and other meds. On the other hand, the response may not be everything that you want. And so, we get started pretty quickly doing this. We follow up very quickly, and then we get on people on as many medications as possible, as quickly as possible.
Mhm. When we're looking at children with HoFH, at what point do you think is invasive cardiac testing recommended? Is that something that you do still while they're very young, or is there a timing for that and other considerations for when to do that kind of testing?
Well, the standard of care is a CT angiogram, and a CT angiogram basically gives contrast, an IV contrast through a peripheral vein, and then you look at the arteries in the heart with a CT scan. So it is definitely less invasive than a cardiac catheterization. And that is actually now the standard of care when you make the diagnosis. So with a couple people, when I've had patients with homozygous FH, I refer them to one of the pediatric cardiologists or adult cardiologists, and that is scheduled fairly quickly to see how much blockage there is right away. And that goes also, in addition, you do the echocardiogram, because sometimes there is relatively early aortic stenosis. I mean, long, long ago, before all these treatments, I was seeing people with homozygous FH, and they both developed very significant aortic stenosis.
Mhm. So kind of in the same vein, I think we hear a lot of conversation these days about calcium scoring. So you had said in your presentation that HoFH is already a high-risk population. Is there value in calcium scoring, maybe before or after cardiac events, or is this population it's not as important? What are your thoughts on that?
Yeah, so I actually would not necessarily do calcium scoring, because I would go directly to the CT angiogram. Early on, some of the plaques are just going to have cholesterol in them. And you would be able to see that on the CT angiogram, and there would not be any calcium. It takes a while for calcium to get in because calcium represents scarring. And most of the time, my use of coronary calcium scoring is in people who do not have homozygous FH, and where, there's a question of their risk, where I don't have a clear-cut diagnosis and I want to see how bad things are. And so sometimes I use it to kind of help people make a decision about whether or not to be on medication.
Mm-hmm. So here is a question of curious to know your opinion on evinacumab in patients with HoFH with hypertriglyceridemia. The person asking the question said they read a paper that it was not working at all.
So it will not work in the pure hypertriglyceridemia patients very well. I mean, and it works a little bit, but it's not all that great from some of the early data. So if you're not really dealing with homozygous FH, you're not going to see, I don't think you're going to see much effect. Now, some people with homozygous FH can have hypertriglyceridemia, but familial chylomicronemia syndrome is actually a different animal. That's a problem of triglyceride metabolism. It doesn't involve the LDL receptor at all. The LDL receptors are fine. They work fine. It's just that people cannot clear triglycerides from their blood.
Mm-hmm. Going back to the slide that you showed, the sort of the inheritance pattern, is there ever a situation where someone can have HoFH, but they only got it from one parent?
Right. So as we do more genetic testing and we learn more about FH and the genes involved in FH, we've learned that it's not just the LDL receptor that can have a mutation. There are other genes that can. And in particular, in some populations, people have mutations of what the ApoB molecule. So apolipoprotein B is a protein that wraps around the LDL. And there's a part of the ApoB that actually fits on the LDL receptor. So if you have an ApoB mutation, it may look like your LDL receptors are not working very well. And ApoB, the gene for ApoB and the gene for the LDL receptor are on two different chromosomes, chromosome 1 and chromosome 19. And so you could actually have a parent who has mutations in both of those, and you could get those two chromosomes, affected chromosomes, from that parent. So you could see a situation where you have somebody who has an ApoB mutation and an LDL receptor mutation, and then passes that exact same problem on to the child, and the other parent could be normal. So there's a lot of little variations here now that actually they're really cool. I mean, in terms of the fact that we are learning more and more stuff about it.
And I know we've seen more people have genetic testing or look into genetic testing for a diagnosis. Would there be a situation where someone had a genetic test that appeared to come back negative, but they could still have HoFH? And what do you do in those cases?
Right. So, there are over 1,000 there are over 1,000 mutations or variants in the LDL receptor gene that have been described and related to high cholesterol problems. But we have not found everything yet. We're still finding them. And so sometimes you get genetic tests that haven't found anything. Other times, depending on the type of genetic test that's done, you can find variants that we don't know the significance because nobody's identified a family with high LDLs that has that variant. It sometimes takes a relatively large family to do that. And so you can have a variety, you can have people come back without 2 genes. Typically they'll have 1 gene and not another. So the genetics have gotten much more complicated, and it really helps to have the genetic testing discussed with a trained genetic counselor or somebody who actually spends a lot of time looking at the genetics of FH. When I do genetic testing, I spend time explaining what the mutations mean to people. But really, genetic counseling is really important when you're doing the genetic testing to kind of explain all this. And I think that it's important for people to know that even if the genetic testing doesn't say you have homozygous FH, that if you clinically have homozygous FH, then you need to be treated with the drugs for homozygous FH.
And this is kind of a 2-part question going along with the different genetic mutations. Are there certain combinations of mutations that make the FH worse? And are those mutations associated with the physical manifestations that you talked about? Because you said those aren't always present. So is there a connection there?
Right. So, I mean, the genetics is not always totally determinant. Okay. But in people who have, say, a large deletion where the LDL receptor doesn't work at all, and they have 2 of those, see that a lot in the French Canadian population, no LDL receptor function, that tends to be worse than people who have, say, 1 LDL receptor that it isn't there at all, and 1 LDL receptor that's kind of tools along at maybe 5% activity. But it isn't always determined. There's a lot more things that we don't know. So yes, the genetic testing does help sometimes, and it can explain a lot. The other thing is that the higher the LDL, typically the more likely people are to have the physical findings. But again, that isn't always the case either. So everybody's different. And there are probably other genes that help determine, why people put cholesterol into their Achilles tendons, and why some people have ARCUS, and why some people have the planar xanthomas on the skin. So I basically am usually not surprised about anything. The longer and higher the LDL has been, the more likely they are to have tendinomas, and you have to know how to look for them. So I spend a lot of time teaching trainees, medical students, residents, fellows to feel Achilles tendons and to look for the xanthomas and what they look like, so they recognize them when they're going out into practice.
I feel like the more questions we ask, the more complicated this gets. Thank you for
like
like
everything else,
Yeah. So you mentioned some of the treatment options and sort of the medications that can be additive. I know from my own experience, there's been a lot of development recently, like in the last 10 years or so, that have really, made a difference for me personally. So when we are able to get HoFH patients to levels lower than they've had in their lives, can we consider ourselves on the verge of a cure, or how do you look at that?
I wouldn't say that it's a cure. I think that it's a treatment treatment that, I mean, the thing about familial hypercholesterolemia is that when you treat people, you make a huge difference. And so, I mean, until we get to until we edit all your genes, we're not really curing it, but we are treating it. You kind of think about this like some other diseases where the treatments are so great, it does look like a cure, but it's not, you still have the genetic issue. And the thing to think about that is with, prior authorizations with my FH patients, and I have to do it every year, it's like the person has not changed from having FH. They still have FH. So there's no reason to say that they should stop the treatment that they're getting that's lowering their LDL levels to safe levels. The statins have changed the entire natural history of heterozygous FH in people treated. And in fact, when you look at the South African data, that when statins became available in the 1990s, that changed the whole trajectory, even in their homozygous patients, such that, when the average age of onset of heart problems was 12, and the average age of death was 18 in the homozygous FH population in South Africa. They don't have apheresis readily available. When the statins came on board, that changed to about an age of onset of events at 28, and delayed the early deaths of many of the patients. We are in a position now where I think we're going to have people where we get the LDL levels low enough that they are going to live longer, healthier lives. And especially if we start early, we are going to prevent them from having the bypass surgery, I hope. And there are new things in development. I mean, there's interesting stuff out there coming up. So
yeah, if you're talking to a parent who has a young child, let's say newly diagnosed, how should the parent be thinking about, it can be intimidating to think about putting your child on medications, injections, procedures. How do you sort of counsel a parent of how to think about treating this, managing stress, anxiety, and things like that in young children?
Right. So people are worried about, the side effects and the effect of all the medications. And I think it's important to put it into perspective in terms of if the levels are really high, this is what may happen to people. And if you really want to avert in a young child really bad things from happening, this is the way to go. And, you have to think about this, suppose you have a child with type 1 diabetes, you have to give them insulin. I mean, that's life-saving. And I think that all of these medications are life-saving medications. And I usually use some of the curves that when I'm talking to people to show them, this is what we can do. We can move these curves. We can change, it's not like, you are doomed to this fate. We can move these curves.
Have we seen any evidence yet? And I recognize it may be too early, but have you seen any evidence that some of these new treatments might actually reverse some of the buildup and things that people are experiencing?
So, I don't think we've done very much in the way of imaging studies yet, but in heterozygous FH or in very severe high LDLs, we have old data showing that when you put people on multiple medications, you actually decrease plaque size. And so when you get the LDL low enough, we have data from other studies showing that you lower the LDL enough, there is a change in what the plaques look like. So this can be looked at by something called intravascular ultrasound, or IVUS, where you put a little teensy ultrasound probe in the coronary artery while you're doing the cardiac catheterization, and you can do measures. You can do ultrasounds of those plaques and see that they actually decrease in size a bit. And that's not been, I don't know if that's been done in homozygous FH, but I don't recall any particular studies lately, but things definitely can be better. And people feel better. I mean, when you get the LDL down, people are often better anyway.
You mentioned, getting the LDL down as low as possible. And this is the question we hear a lot. Is there such a thing as too low?
No.
Can you be dangerously low?
So there is one situation in which the body doesn't make any LDL, and that is problem. That's extremely rare. I mean, that's even more rare than homozygous FH.
Mhm.
But in fact, the problem is that when you do the calculations for LDL, most of the formulas that are out there for calculating LDL are not as reliable when the LDL is below 70. So
Mhm.
even though people may show up with LDLs that are about 5 or 10 in some of our patients who didn't start out that high, their LDLs are higher than that. And there are people who get along really nicely with extremely low LDL levels. And that we've seen in people who have mutations in that PCSK9 protein, where they don't make any PCSK9 protein. Their LDL receptors are like super receptors, and they clear LDL so well that their LDL levels run about 10. In the
Mhm.
clinical trials that were done with evolocumab and alirocumab, those two PCSK9 monoclonal antibodies, a lot of people were down in the LDL of 10, 20, 30 range. And looking at those data, there were no problems at the low
Mhm.
LDL levels.
Awesome.
So I'm not worried about it. And if I'm starting out with an LDL of 750, I want to get as low as I can.
Right. Yeah, absolutely. A question here. So you are obviously at a major medical center. You are an expert. What advice would you give to someone who may not be near a major research center? Like, is this a condition that you could manage with a family care doctor if you're not near a major center? Or what advice would you give someone in that kind of situation?
Right. So, I mean, I think that we now have a network of people who know about FH all over the country. And I would say people should get connected with the Family Heart Foundation to
Mhm.
locate somebody who has a reasonable knowledge. The other thing is that many of us talk to each other all the time. And so people who belong to, say, the organization I've been involved with, the National Lipid Association, um, will send out emails or will bring cases. And so we do a lot of networking to discuss cases. In fact, there's like a whole listserv of pediatric lipid people talking about cases online.
Mhm.
And so I think there are ways to get connected to somebody. And, people can see a specialist once, get put on all the right things, and only follow up periodically. But
Mhm.
there's certainly not, I think there are not enough of us to go around, but we will make every effort to try to, find help for people.
Mhm. Yeah. Yeah, I think in my own personal experience, I've had great, really caring family doctors but it's just different when you have the opportunity to really plug into a network of people who are really knowledgeable in depth
Yeah,
on this.
I'm all about networking. I'm old enough
Yeah,
to know a lot of people. So
that's good. The network is very important. Um, let's see, I'm looking to see if I've missed any questions. If you've got questions, we do have roughly 7 more minutes or so feel free to pop those in. I think I had one and now I've lost it. Let's see. Oh, I know. Um, as someone myself who is now in my 40s, and I was treated from a young age, but not with all the medications that we have now. And I did still experience heart disease, heart attack. Is there hope for young people starting out with some of these new medications that they may in fact be able to avoid this kinds of cardiac events, or is it even at low levels we're at higher risk?
I mean, I think that if we start out early enough and the arteries are still pristine, and get the LDL low enough that we can do something. So I am a big proponent of what is called primordial prevention,
Mm-hmm.
where you find people and you start treatment very early and you treat them before they've had a chance to build up any plaque. And so
Mm-hmm.
I think that the way we're going, I'm not sure we're quite there yet, but I think the way we're going, that we will be able to do this in the future. That
Mm-hmm.
once we identify, somebody very young, we can start treating right away.
Mm-hmm.
And there are some, over the next few years, CRISPR therapies, gene editing may really provide a lot of impact in terms of being able to do something.
Mm-hmm.
Certainly in heterozygous FH, I mean, if you get an HeFH child starting before pretty, you can keep them from having events. And we have data from that from the Netherlands. So I think if we can get the LDL low enough, we can keep people from having, bypass surgery. The aortic stenosis is a little different because that may be related to some other things like lipoprotein A. We're getting there also. We will eventually have things that lower lipoprotein A.
That's great news for the future. That gives me a lot of hope. I know it does to a lot of others as well. I'm going to do a last call here if anyone has any questions. Oh, there we have one. Okay. Do you think that genetic testing will help speed up the goal of early identification and early treatment?
Well, I think it could. I think the main issue is getting it more widely available and doing it as early as we can. It's not been always easy to get it covered by insurance, and there's some out-of-pocket expenses. I think that you could consider genetic testing really early. There was a project in the United Kingdom of testing all kids at age 1 when they got their shot. So when they come in and they're already screaming with their immunizations, you do a heel stick and measure their cholesterol, then you do the genetic testing, and then you can find the parents as well. I mean, I think that just starting as early as possible, and if people know that they have high, making sure that everybody knows what their cholesterol levels are. I mean, know your number is kind of the mantra. If you know your number, and you might also want to ask your the person who you're going to have a kid with what their numbers are. And there is precedent for this. I mean, the precedent is in sort of certain communities, people say you need genetic testing, say for Tay-Sachs, before we will consider anything. And so I think that we could get there eventually, but you have to be careful about, what the ethics of this. There's some issues that need to be considered.
And do you think that you mentioned the heel stick, do you think that newborn screening for lipids is a possibility in the not too distant future?
I think the problem is that levels in newborns are not stable, and people have done cord blood and where you're very suspicious, but it may be a little difficult sometimes to make the diagnosis in a newborn. I think where you think that there's a likelihood of homozygous FH, you could do cord blood, and that would be reasonable. I'm not sure that universal newborn panel, how well that will work. I mean, because the cholesterol levels may be high very soon after birth, especially with breastfeeding. They go up with cholesterol levels go up with breastfeeding.
I think the follow-up is maybe gene testing on a newborn panel.
Right. I mean, I think the major problem with that is that it would be quite costly. And then the other problem is that, just because the genes doesn't know that is always going to predict exactly what things are going to look like. So I think starting by at least age 1, or making sure that people actually know if they have high cholesterols, because the cascade screening is going to be one of the best ways to figure out what's going on.
Well, we are close to the end of our time, Dr. Goldberg. So I want to thank you. It's always amazing to hear a term like high cholesterol, and it sounds very straightforward. And the more we talk, the more complex it gets. And there's so much going on right now in a very positive way. So thank you for your time and for walking us all through all the various pieces and parts and how they all fit together. It's been fantastic. And thank you, everybody, for your questions. So thank you, Dr. Goldberg.
Thank you for having me. My pleasure.
Yeah, and I'm just going to kind of wrap us up here just with a reminder. Dr. Goldberg mentioned some of the resources that we have at Family Heart Foundation. These were the flyers that she mentioned that we showed that kind of walk through HoFH, what is it, what to expect, that you can download these from the Family Heart website. You can share them with family members. You can take them to your care providers, just share it with whomever you like. It's a tremendous resource to have there. We also have, we've talked about some clinical trials tonight. I know for myself personally, I've done 4 or 5. It's been one of the most rewarding things I've ever done. I consider some of the drugs on the market my drugs because I got to participate with it. But if it's something that you feel like might be a fit for you or your family, I'd encourage you to look at the search engine on the Family Heart website, and you can see if there might be trials around you that you might be interested in. We also have a care navigation center at Family Heart Foundation. So if you or a patient or a family member are looking for a care provider, if you're having a hard time finding an expert, you can look on our website. You can also speak with one of our care providers, our care navigators. They will get on the phone with you, answer your questions, and walk you through this process to get you to the best person to help you with your treatment and care. And of course, if you would like to join me in becoming a Family Heart Ambassador, we would love to have you. Like I said at the beginning, this has been one of the most rewarding things that I have done in my life, to feel like I'm having an impact, sharing my story and raising awareness. Visit our website, send us an email. We'll have the contact information here at the end, but we would love to have you help us raise awareness, raise funds, support others. It's a tremendous community, and we'd love to have you be an ambassador with us. And of course, if you would like to support Family Heart Foundation by making a donation, we would very much appreciate that as well. You can go to www.familyheart.org/donate and make a donation to help us continue to have this kind of programming and continuing to make a difference for families living with FH and elevated Lp(a). Here is our contact information, the website, familyheart.org. info@familyheart.org is where you can reach us by email. The phone number there is 582-203-0755. We'd love to hear from you. We appreciate everyone joining us again here on Rare Disease Day. As an HoFH patient, I thank you for your interest, for your support, and thank you again to Dr. Goldberg for sharing all of your expertise. Very much appreciate it. Thank you all very much, and have a great evening or day. Thank you.